Good afternoon, everyone. You are very welcome to the Introduction to the Enhanced Community Care ECC programme webinar. The panel will be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC or laptop screen. If you're using an iPad, you will find this feature located at the top of your screen. Without further ado, I will now hand you over to your host, Colette Ansbro, General Manager, Chief Officer's Office, ECC. Thank you.
Thank you, Helena. And I wish to extend a warm welcome to everyone this lunchtime. This webinar is to introduce the rollout of the Enhanced Community Care Programme across Community Healthcare West and Saolta University Healthcare Group. Today's event is being recorded, and this recording will be available to view on the Community Healthcare West YouTube channel. If you've registered for the webinar using your email address, you'll be sent a link to the recording once it has been added to the channel. Please note that the video will only record the panelists on screen and not the audience members or chat feed. For our audience attendees, you will note that your audio and video is turned off. This helps to assist us in managing the online event more smoothly. There will be a Q&A session towards the end of this webinar. During the webinar, you can put your questions into the chat box for answering at the end of the webinar. A frequently asked question document will be produced following today's session, as we anticipate we won't have time to address all queries raised, and we will be circulating a FAQ document in the coming week. If you do have any technical issues or questions during the event, please post a message to host in the chat box in the bottom right, and we will do our very best to respond to your comment or query. Please find the links to two important documents in the chat. They are the ECC Implementation Guidance for ICPOP, Integrated Care Programme for Older Persons, and the National Framework for the Integrated Prevention and Management of Chronic Disease in Ireland. So without any further delay, I will commence this lunchtime session. And I would like to introduce our first speaker, who is Breda Crehan-Roach, Chief Officer, Community Healthcare West.
Thanks, Colette, and good afternoon, everybody. On behalf of Tony Canavan, on my left, your right, and I'm delighted to welcome you and to open today's webinar. This is the rollout of the Enhanced Community Care Programme across Community Healthcare West and Saolta University Hospital Care Group. Firstly, I would like to take this opportunity to acknowledge the integrated approach adopted here in delivering this ECC programme, and to highlight the conjoint working, commitment, dedication of staff across both Community Healthcare West and the Saolta University Healthcare Group, and indeed GP colleagues in the implementation of the programme across Galway, Mayo and Roscommon. This is part of Saolta Care, which has seen the investment of over 372 staff into community teams to develop services within 4 key areas for people living within our community. And the key areas are, and very quickly, developing of an integrated care programme and teams for older people, developing the integrated care teams for chronic disease management in respiratory, cardiology and diabetes, the development of 9 healthcare networks, or commonly known as CHNs, which afford integrated working across all community services, and to further the development of community diagnostics with direct GP access. In addition, these teams are augmented by health and wellbeing staff, which has seen an even greater focus on health promotion and prevention within the management of chronic disease across the population we serve. The key benefit of these teams to people living within our communities are greater service user patient access to specialist multidisciplinary team care within the community, greater GP access to specialised clinical expertise and diagnostics, integrated pathways between GP, community and acute services for older persons with chronic disease, diabetes, respiratory and cardiology, which will ultimately mean more timely access for service users and patients. The development of health promotion and prevention agenda within the chronic disease management. These services are developed alongside a population health approach, and finally, it's supporting Saolta Care policy of shifting care left from acute care into community care. We are moving lower level acuity work into more appropriate community settings. This webinar will focus on the 4 areas as I've already outlined, and we are delighted to hear from clinicians, from GPs who are implementing these services, and indeed from service users and patients who have benefited from these services to date. I'll now pass you back to Colette. Thank you.
Thank you, Breda. I would now like to introduce Mary O'Halloran, who is our General Manager in Primary Care Services.
Thank you, Colette. In Community Healthcare West, there are 9 community healthcare networks. There are 5 networks in Galway, 3 in Mayo and 1 in County Roscommon. Prior to the full-scale rollout of the networks, there was a test or pilot site chosen in each CHO. This was to test the hypothesis of the network model and to take any learning received prior to full-scale rollout of the model. In our CHO, the pilot site was the Tuam network, Tuam, Athenry, Loughrea and Abbey-Knockmoy. In 2019, a network manager was appointed to this pilot learning site. The role of the network manager is a new role. They are responsible for the primary care services within their network and also responsible for the operational line management of certain staff within that network, namely administration staff and therapy staff, including dietetics, occupational therapy, physiotherapy, speech and language therapy, podiatry, and social work. This dual management process is a new concept in primary care. The role of the therapy manager has also evolved under enhanced community care. They are responsible for the clinical governance and the service development aspect of their service. This is an important function, and it is to ensure that patients are receiving a high quality service. In 2021, we began the process of implementing the full-scale rollout of the community healthcare network model. This involved appointing a network manager to each of the other networks, and between 2022 and 2023, all 9 community healthcare networks in our CHO have become operational. As part of the learning site, a GP lead was appointed, and their primary role and function is to be the communication bridge between the HSE and the GP community. Each network has their own management team, comprised of the network manager, the GP lead, the assistant director of public health nursing, and senior therapy staff from each discipline. The network managers are responsible for re-establishing the primary care clinical team meetings using the integrated case management approach. Primary care clinical team meetings add value to patient care as the full multidisciplinary team provide input and support to the client. And now I would like to introduce a video from the Shantala primary care team. Thank you.
I provide operational line management to the staff who are aligned to the network. A key part of the role is promoting integrated care, multidisciplinary care within the network. Our ultimate goal is to provide a coordinated, accessible, high quality standard of care in our community to people who live in our community. So today we're here at the Shantala Primary Care Team meeting. The Primary Care Team meeting involves the multidisciplinary team coming together to discuss complex cases. These meetings might happen in person or virtually. The team meeting also provides staff with an opportunity to work in a multidisciplinary way to ensure that we provide the best, the safest care to service users in our community.
In my role as clinical coordinator for the Shantala Primary Care Team, I organise and chair the primary care team meetings monthly. I prioritise referrals for discussion at these meetings in partnership with my multidisciplinary team colleagues and with administrative support. I also ensure that actions agreed at these meetings are implemented, documented and reviewed as appropriate. I also liaise with GPs, external agencies of other teams as appropriate to the clinical case discussions. In my role as senior occupational therapist, I work with adult clients to regain or maintain their independence in activities of daily living. I assess their cognitive skills and assess their home environment to promote independence and prevent the likelihood of falls or injuries at home. Interventions are varied and depends on the goals chosen by the clients involved.
I provide care to adults with a variety of conditions and needs. I aim to help people who have experienced an injury or an illness. I help them to regain their health and mobility through exercise and movement.
I meet and greet the service users when they come into the clinic. I provide immense support to the Saolta primary care team. I coordinate with the team to get the details of patients to be discussed at the primary care team meetings.
My role involves two parts really. Firstly, I'm the GP lead for the network, which involves sitting on network committee meetings and being involved in the development of local primary care services. I suppose my role is an intermediary between GPs and what's happening in the primary care services and the community network. So I bring information to GPs and also advocate for GPs in terms of how services are delivered to try and deliver them in the most patient-centred way for our patients in the community. The second part of my role is being involved in the implementation of the Enhanced Community Care Scheme and the development of services locally in the community, including chronic disease hubs and integrated care of older people and more increased access to diagnostics in the community. And that involves sitting on lots of implementation committees to try and make sure that from a GP perspective that's considered in terms of the development of referral pathways, how the IT systems work, how we interact with each other to make sure that as these services are delivered that it works well for GPs as well as the staff in the community.
Thank you, Mary, and to the primary care team in Saolta. I now would like to introduce Professor Michelle Canavan, Professor of Older Adult Health at the University of Galway, Clinical Lead of Galway Integrated Care Programme and Consultant Geriatrician at University Hospital Galway and Community Healthcare West.
Thanks, Colette, and good afternoon, everyone. I'm delighted to represent the development of integrated care for older persons here in Galway, Mayo and Roscommon. And I suppose just as I start, I think it's really important that we all understand why older people need integrated care and what integrated care actually means for them. For older people who are frail, possibly cognitively impaired with mobility issues, it is sometimes very daunting to try and navigate our healthcare system. And in the past, they may have presented on multiple occasions to the acute hospital setting in order to access the care and support that they required. This model unfortunately results in bad outcomes for older people and can lead to loss of function and increased risks of readmissions and admissions to nursing homes. However, with the development of these integrated care pathways, we have the opportunity to develop end-to-end pathways for people, for older people who need this care. And this is an alternative where they can access comprehensive geriatric assessment, which is coordinated, and we try and deliver it as close to their home as possible, either in the ambulatory care hubs, in their own homes, or at their local primary care centre. The vision of this service is to empower healthy ageing in people's homes and communities. This service has evolved over the last few years with initial Saolta Care funding followed by the ECC funding, and we now are fortunate to have 4 integrated care teams for older people and 4 frailty type teams at the front door of Mayo, Roscommon, Portiuncula and Galway hospitals, which link very closely with the community teams. The teams consist of consultant geriatricians like myself, specialist nurses, physiotherapists, occupational therapists, speech and language therapists, dietitians, social workers, therapy assistants, and our administrators. The older person receives a holistic assessment which focuses on their needs with a huge focus on maintaining physical and cognitive independence, minimizing use of medications where possible, and building the supports and wraparound services in the community which allow them to remain at home for as long as possible. There's also a strong focus in this programme on improving the inpatient care and the transitions of care for people from hospital to short stay to home. And this often happens at the front door in ED, where patients might be assessed by a frailty first or frailty at the front door team. If they're able to go home, they can be linked with the integrated care team in the community or maybe community reablement beds, so that when they're discharged, they have this continuity of care. Feedback to date from older people who've used this service and their carers has been very positive. They feel listened to. They feel they have been given time and that their needs are addressed in a holistic way. Most importantly, they feel they have a point of contact with the healthcare service, which is responsive when things go wrong and when they need more support. We're now going to show you a short video where some of our team members explain what they do within the integrated care teams for older people. Thank you.
I go to reception when the patient arrives and I meet and greet them and bring them up to the multidisciplinary team. and help them to relax, I suppose, on the way up, just to settle them.
Part of my role is to support the multidisciplinary team and to help organise and schedule the patients both in our Castlebar base and our outreach hubs across Mayo.
As the first community connector in the post nationally, my role is to connect older people back in with the community organisations and services to increase their social support, health and well-being. Together with the older person, we do a well-being plan, and that empowers them to take control of their well-being.
I think it's a terrific place. You come here, you're seen straight away, and the staff are so lovely, so friendly.
I assess older persons with complex healthcare needs, such as recurrent falls, frailty, dementia, and polypharmacy. And as a team, we deliver a patient-centered care plan with a multidisciplinary approach and under the supervision of the consultant geriatrician.
I commenced the comprehensive geriatric assessment. I'm able to perform a full episode of care from admission to discharge, including assessment, diagnosis, treatment and review. I usually see the older person in their own home and bring follow-up into the local primary care centre. I identify issues for the older person and try to perform interventions to address these. I present the older person to the consultant geriatrician and refer on to the relevant multidisciplinary team members. I am a direct point of contact for the older person and their family.
I assess the client's mobility and overall function. I look at their strengths, balance and coordination amongst other things. So together with the older person, we set physiotherapy treatment goals, and along with the physiotherapy assistant and wider multidisciplinary team, we instigate an action plan and programme in order to meet these goals.
It was extraordinary. The staff were wonderful. I was delighted with it. You're treated here like a person, not like a number.
We help the older people that we work with to overcome or work around any problems they might be experiencing in their daily life by looking at how their health condition affects them.
We help older people to find practical solutions to everyday challenges that they have. For example, physical interventions like helping them to get in and out of the bed or hanging clothes on the line.
We also explore how to make the most of your memory and the concentration if that's something the older person is worried about.
What matters to the older person, their hopes and wishes, is our focus.
Thank you, Michelle and the ICPOP team. I will now introduce a pre-recorded video of Professor Sean Dineen, Consultant Endocrinologist in Galway University Hospital, and until recently was our National Clinical Lead for the Diabetes Clinical Programme.
Hello, my name is Sean Dineen. I'm a consultant endocrinologist in Galway University Hospitals, and I lead the Diabetes Integrated Care Implementation Group as part of the Enhanced Community Care Programme in Saolta Community Healthcare West. Care for type 2 diabetes has traditionally been very hospital oriented in our area. We have many patients with stable type 2 diabetes attending our hospital clinics who really don't need the input of the hospital-based team. The chronic disease management payment to our GP colleagues has, in the last 2 or 3 years, really transformed our approach to chronic disease management. And now we're seeing GPs and practice nurses very comfortable with managing type 2 diabetes. The Enhanced Community Care Programme of the HSE is a game changer for diabetes care in our area. We're now appointing community specialist teams, including clinical nurse specialists, dietitians, podiatrists, who will be implementing our model of care for type 2 diabetes in an integrated way, promoting diabetes prevention, self-management education, and high-quality care along the course of the disease. It will also enable us to implement our diabetic foot model of care and allow the hospital-based specialist team to concentrate on the complex end of the care pathway and dealing with people living with type 1 diabetes, technology, diabetes in pregnancy, and so on. So our team is not yet complete. Saolta, CHW are still, we're still in the recruitment process, in particular for consultant diabetologists to the Ballinasloe and Galway hubs, but we're very excited about the opportunity that ECC presents us. Thank you for your attention. I'm going to hand over now to members of the community specialist team and a service user.
A large part of my job within the hub really is organising and running the Desmond programme. So this is a structured self-management group education programme for anybody living with type 2 diabetes. I also run one-to-one clinics, and this is really for those with type 2 diabetes with more complex needs. For example, those with celiac disease, chronic kidney disease, but they have a background of type 2 diabetes. I also work very closely in a multidisciplinary team alongside my clinical nurse specialist and podiatry colleagues. So there would be overlap between our client lists, and essentially we're trying to just get best outcomes by working together with those clients.
I look after patients with type 2 diabetes, and GPs refer these patients to the service, and we accept patients who have a HbA1c of greater than 58 millimoles per mole. They're usually on 2 or more medications for their diabetes. They may also send them to my service for insulin initiation or medication titration, or perhaps they might have difficulty with hypoglycemia. As part of my role in the community, I am a Desmond educator. I work very closely with podiatrist and with dietitian. We're a diabetes team within the community. So this multidisciplinary approach and communication with the different healthcare professionals is key really to getting the best outcomes for patients.
I provide podiatry treatment to people with diabetes. As part of the service, I carry out full diabetic foot assessments, and this consists of a vascular assessment, and that's made up of a hands-only palpation of pulses, and I also use a Doppler to find the pedal pulses in the foot. I also carry out neurological assessment of the foot, and I also look at foot structure and footwear. An important part of the service is education, the importance of foot health protection, and we give general advice on foot care and footwear. After I first assess a patient, I send a letter just with the results of the diabetic foot assessment and with any treatment plan that's been agreed, and that's forwarded on to the GP.
I was diagnosed first in October 2020, and Dr. Enda suggested I come here as part of the service to engage with what I call my 3 Charlie's Angels. Since I started coming to them, what I felt was that because of their information that they gave me, because of the supportive nature and the friendliness that they portrayed to me, it helped me actually embrace the condition and work with them to become the healthiest version of myself that I am today. Because it's a local service where I didn't have to travel, because it was so friendly and supportive. I feel now, because of the positive experience, that I'm healthier and happier than I have been in years.
Thank you, Sean and the diabetes team. I will now introduce Dr. Susan Conley, consultant cardiologist in Galway University Hospital and Community Healthcare West.
Good afternoon, everybody, and I'm delighted to tell you about the cardiovascular aspect to our new community programme, and I really think it has the potential to transform the way we deliver care to our cardiovascular patients. The cardiovascular hub team includes myself, specialist nurses, a physiotherapist, cardiac rehabilitation nurses, a physiologist and psychologist. And our overarching aim is to truly provide integrated patient-centred care, focusing in particular on 3 particular patient groups: patients with heart failure, patients with atrial fibrillation, and patients who require prevention and cardiovascular rehabilitation services. Patients who will benefit from the hub will be identified in 2 main ways: from the inpatient cardiology service in Galway University Hospital by members of the hub team who will go into the hospital, and also, of course, via referrals from our primary care colleagues. Being seen as an inpatient by the hub team, I think, is crucial to establish that seamless link between the care team and patient at the very start of their journey. And the aim will be rapid follow-up in the hub to provide support to patients in that early discharge period when they're feeling very vulnerable. The team will work with the patient to help optimise their lifestyle, manage their risk factors, and ensure they're on good doses of cardioprotective drugs, as well as providing education and enhancing self-management skills. We are going to have a strong emphasis on choice for patients in terms of venue, as well as the option of virtual attendance. Very exciting, we'll be harnessing digital technology to monitor things such as physical activity, heart rhythm and blood pressure remotely. And this will help overcome barriers such as rurality and time for our working patients to make their care as efficient as possible. And we will also be offering outreach clinics to help address the needs of our more rural patients. The focus of the service, though, is not just about a patient's medical care. It will also aim to improve our patients' psychosocial health through empowering our patients with self-management strategies, lifestyle changes, and also access to a dedicated cardiovascular psychologist. Many of our patients have multimorbidity, that is 2 or more chronic conditions. And I think this is where the hub will have a unique role to play, because we will have 3 disciplines, diabetes, cardiovascular and respiratory, working together with ICPOP and older people services. And we can then really provide a more streamlined service, reducing the number of appointments our patients with multimorbidity have to attend. Key to the success of the hub will, of course, be working with primary care, and we're very lucky that the cardiology aspect will have a GP attached to the hub 1 day per week. We'll soon be starting our rapid access clinics so patients can have their investigations and specialist opinion in a one-stop shop approach. And our primary care practitioners will also be able to refer patients directly for diagnostic tests such as echocardiograms and so on. And we hope to open up the hub service to primary care by May of this year. We've already started taking patients from our inpatient referral route. And I'd now like to introduce you to a short programme that will have members of the cardiovascular team describing their role.
A key part of my role is to provide individual psychological therapy to patients for whom their mental health difficulties are getting in the way of them engaging with their cardiac rehabilitation programme or in their recovery more generally. I also offer a cardiology drop-in clinic where patients can avail of a single individual consultation with me where they can discuss their concerns and I can signpost them to relevant information and psychological supports. I created this signposting booklet, which is a guide to psychological supports and resources, and this contains helpful information and links to physical and mental well-being. And this guide is available through the Cardiology Hub, and it will also be available on the Galway University Hospital website on the psychology webpage that is currently in development.
My primary role will be delivering cardiac rehabilitation. So cardiac rehabilitation is the process by which patients with cardiac disease, in partnership with a multidisciplinary team of healthcare professionals, are encouraged and supported to achieve and maintain optimal physical and psychosocial health. I'm involved in assessing patients, exercise testing and prescription, and encouraging them to engage in regular physical activity and exercise. So I also explore goals with each patient individually and work towards achieving these goals over time. The overall goal is that the patient achieves lifestyle changes.
My role as a clinical nurse specialist is to care for patients living with cardiovascular disease, heart failure and atrial fibrillation. I will provide education to both patients and their families on their condition and support self-management. It's also my role to ensure optimisation of medical therapy by collaborating with both the acute and the community integrated care multidisciplinary team. I hope that my role will allow for patient choice and that it will also empower patients to manage their own condition.
Thank you, Susan, and the cardiology team. I will now introduce Dr. Sinead Walsh, consultant in respiratory medicine.
Thank you, Colette. I'm delighted to talk about the Respiratory Integrated Care Team. So our overall aim is to provide timely access to specialist respiratory care for patients with suspected or confirmed asthma or COPD in the community. Early access to spirometry with reversibility by our community respiratory physiologists will allow a diagnosis of asthma or COPD to be made. If the patient has persistent symptoms, they can be reviewed by me, the integrated care consultant, and appropriate treatment can be commenced. The interventions provided by the Respiratory Integrated Care Team will be focused and specific, allowing the patient to develop the skills to self-manage their asthma or COPD and supporting GPs to care for patients in the community. As the service grows, we will have oxygen clinics and one-to-one review clinics by our respiratory specialist MDT members. This team is essential, and we will hear more about their roles now.
As respiratory physiotherapists in the hub, we provide specialist assessment and interventions for patients with COPD and asthma aged over the age of 16. We also develop individualised self-management plans in conjunction with patients. We liaise regularly with the multidisciplinary team.
I work alongside the physiotherapists in delivering exercise classes. I actively engage with patients throughout the duration of the programme, monitoring their symptoms, delivering education sessions and intervention when required. My role in the community is to provide specialist respiratory nursing interventions to patients diagnosed with asthma or COPD. Our overall aim is to provide services closer to patients' homes. We also aim to equip these patients with the necessary tools needed to be able to self-manage their own illness.
I work alongside physiotherapy and my nursing colleagues to deliver an 8-week pulmonary rehab programme in a community setting. The programme aims to improve the patient's exercise capacity, reduce their shortness of breath, and also improve their quality of life. We do this by providing them with an individualised exercise programme specific to their ability and also taking into account their comorbidities and their level of breathlessness. The programme also provides a structured interactive education component and advice and support then for the patient to help them self-manage their chronic condition.
Health promotion is part of the Health and Wellbeing Division in Community Healthcare West. And part of my role is to work with the respiratory team in relation to many different areas, including physical activity, healthy eating and mental health, along with our 2 key priority areas, the first one being the Making Every Contact Count programme and our Quit Smoking West service. Promoting staff health and wellbeing is also a key aspect of our work. Health promotion and improvement officers working with our multidisciplinary team colleagues and our self-management support colleagues can and will make a real difference to people with chronic disease.
I'm delighted to be able to participate in the pulmonary rehab hub here in Westside Centre in Newcastle. It's a fabulous facility, it's right on our doorsteps, and you get exercises that you can do at home as well, which is very, very beneficial, and the social aspect is just wonderful.
Thank you to Sinead and the respiratory team. We now have our diagnostics pre-recorded video. I would like to introduce Seamus Byrne, General Manager, Mayo Roscommon Primary Care Services, and Eddie Conran, Radiology Services Manager, Mayo University Hospital in Castlebar.
I co-chair the Diagnostics Implementation Group. Our group is made up of representatives of ICPOP, Community Healthcare Networks, GP representation and the Saolta hospitals. We, in the last 6 months, developed a 5-year diagnostics implementation plan for Community Healthcare West, covering Mayo, Galway and Roscommon. And the objective of this plan is to develop the delivery of diagnostic services in the community as opposed to the hospitals.
We have a very strong relationship with our primary care colleagues across Mayo. We have numerous satellite radiology units around the county that are totally integrated with the core unit in the hospital in Castlebar. We have primary care ultrasound present in 3 sites now on a daily basis. That's Claremorris Primary Care, Castlebar Primary Care and Ballina Primary Care. On top of that, we're also providing satellite X-ray services in the Castlebar Primary Care Centre on a daily basis. And we also have an outreach X-ray service in Belmullet and Ballina District Hospitals. And we found it a really, really effective way of giving that access to patients that have been referred from their GP to those two primary radiology tests, ultrasound and X-ray. It's very popular with staff, it's very popular with patients, it's very popular with GPs, a very positive development. A lot of patients who come in for these kind of tests, they're not unwell or anything, they just need to have a checkup from the GP, and it's far more appropriate that they're seen in this setting than coming into the acute hospital system, both for themselves and for the other patients in the acute system. So it's just a win-win for everyone.
Thank you, Seamus and Eddie there and the diagnostics team. I am delighted to introduce our next video of Jarlath Duignan, GP in Tuam and GP lead for Network 7.
Hello, my name is Jarlath Duignan and I'm a GP in Tuam. I'm also the GP lead for my local network. This network, which includes Tuam, Athenry, Loughrea, was a learning site network and as such piloted a lot of the initiatives being discussed today. We have had an ICPOP service locally for the past 2 years. This has allowed me and my colleagues to have our elderly frail patients, many who are prone to falls, to be assessed by a consultant geriatrician and team at the local primary care centre. Many of these patients have multiple morbidity and polypharmacy issues, and having a holistic review locally and timely has been hugely beneficial to them and their families. The introduction of direct GP access to diagnostics has also allowed greater patient care in the community. We as GPs can order CT scans, MRI scans, X-rays, DEXA scans electronically for our patients, and these tests are usually done within a matter of weeks. We also have an ultrasound facility now at Tuam Primary Care Centre. All of this is allowing for patients to be managed locally and again reducing unnecessary referrals. In terms of chronic disease management, this network piloted the rollout of an integrated diabetic team 3 years ago, and this has been extremely beneficial to us. To give an example, I recently had a man with type 2 diabetes who became unwell with weight loss and rapidly rising HbA1c. I contacted the local CNS who saw him that week. She had him seen by the consultant the following week. He was commenced on insulin and has done very well. And again, this shows how care can be provided in a timely manner at a local level, and the trip to the local acute hospital was avoided. So all very beneficial. We also have at the moment the rollout of cardiac and respiratory teams happening, and we will have access to echoes, spirometry and other services provided. All of this will be very beneficial to us. It will allow better support to general practice. It also allows for greater integration of services and ultimately and hopefully in the long term we'll see greater and improved patient care in the community.
Thank you, Jarlath there. We'll now see our pre-recorded video covering our patient and service user engagement for Community Healthcare West. I would like to introduce Elaine Newell, Project Lead for Enhanced Community Care, and Liz Cotter, a service user.
I lead our team on our patient, service user and staff engagement work for the community of Galway, Mayo and Roscommon. Our engagement work is called Better Together to improve health and social care. Through feedback and focus group sessions with the public, we work together and we have developed 4 key themes. These include affording people compassion, dignity and respect, offering coordinated care, support and treatment, offering personalised care, support and treatment, and support people to recognise their own strengths and abilities in enabling them to live independent and fulfilling lives. The public, they look to us, the HSC, to include these foundations in their experiences of care. Within these focus groups, we have older persons and people living with chronic conditions. They come and they share their lived experiences of care with us. We talk about how we can improve these, and they offer us concrete ideas and suggestions for service improvement. We continue to reach out to the public in relation to this engagement work so that we can have more people involved and we'll have representation across different groups. We also deliver staff workshops focusing on patient and service user engagement. This assists our staff so that they can develop their confidence and skills and knowledge for implementing meaningful engagement in their everyday work. We continue to work towards meaningful engagement becoming normal practice in our health and social care.
Hi, my name is Liz Cotter and I'm a service user as part of the Better Together project. We meet and we work together to find ways to improve communication and therefore the experience of both healthcare workers and service users. So we have come up with themes of where problems lie when you go to a meeting with the healthcare professional. Things like the information that you're given when you receive a new diagnosis, whether the information is verbal or whether it's written material, it should be clear. So difficult language or medical language that people can't understand is not useful. If a person doesn't feel comfortable, they may be afraid to ask questions. They come out with unanswered questions and it's frustrating. It has happened to me. And then there can be a very refreshing day where you go to visit a health professional and they have read your notes, so they know all your information. And then it's a really useful appointment. The language that's used at appointments is so important.
We've now reached the Q&A section of this webinar. There are some very interesting questions coming through, and we may not be able to get through them all here today, but however, we will be producing and publishing a frequently asked document in response to this session. Anyone who's registered for the webinar using their email will receive this FAQ by email in the coming week. So now we'll go to our panelists, and really our first question here is being directed to Susan Conley, consultant cardiologist. And the question coming in is, what is GP access to diagnostics?
Thanks, Colette. Yeah, no, that's a great question. So the focus over the past year has been the assessment of existing services to inform the development of a comprehensive 5-year phased diagnostic service delivery plan. There will be diagnostics in terms of respiratory, spirometry, as Sinead said, cardiology, so direct access to echocardiography, and then direct access to radiology. The service that currently exists for direct access to diagnostics in terms of radiology has been extended to the end of March 2023. The ultrasound contracted service from Affidia is being re-tendered, and we have provided GP feedback to the National Diagnostics Lead. We will be scheduling a number of information meetings with GPs over the coming months to update them on the developing pathways for diagnostic supports. And the first meeting in Go will be on the 25th of March in Cree House. We are struggling with the recruitment of cardiology physiologists. There is a national shortage, but we have some active plans to solve this in progress.
Thank you for that. Our next question is regarding accommodation. I'm going to direct that to Mary Ward, Head of Service and Primary Care. And the question is, what are the timelines, Mary, with the hubs?
Thank you, Colette. Yeah, for the last 18 months, we've been working with our estates colleagues to get approval and secure funding for accommodation for the ECC programme. And the solutions are both short-term and long-term, including the maximisation of use of clinical accommodation across all of our sites, including using existing buildings and using buildings of organisations that we are in partnership with, such as the Cree building. Our vision is that all staff across the programmes, ICPOP, chronic disease and networks will be co-located in an ambulatory care hub. The long-term solution for the Galway hub is a primary care centre in Knocknacarra and Galway City West. The building in Knocknacarra has been purchased and the schedules of accommodation are currently being agreed. We expect to be operational within about 2.5 years. And the primary care centre in Galway City West is currently in planning stages. We have also secured office accommodation across in Dangan and Ballybrit, which will allow us to reorganise current space within buildings to maximise use of clinical accommodation. Examples of that are St. Francis Unit and other buildings across Galway City. In Mayo, the long-term plan is the extension of Castlebar Primary Care Centre. Again, we've received planning permission for this, and schedule of accommodation has currently been agreed. In the short term, we are working again with our estates colleagues to secure office accommodation, which will allow us to reorganise current space in order to free up clinical space. Ballinasloe, the long-term solution of Ballinasloe would be a primary care centre. In an interim solution, we continue to work with our estates colleagues to secure that solution. Ballinasloe would be our highest priority for accommodation for the programme. There are a number of other developments throughout primary care, including the development of an X-ray facility in Tuam Primary Care Centre. Elements of the programme for ECC will be outreach across Galway, Mayo and Roscommon. So we'll be using existing space across those 3 counties in our primary care centres, other health centres and other space that's available to us to deliver those outreach clinics. And a good example of this would have been the outreach clinic recently held by the ICPOP team in Clifton. And we plan to follow that example across all the programmes. Thanks, Colette.
Mary, thank you for that comprehensive update on all the hub status of the hub. Sorry, apologies. The next question coming in is really directed, I suppose, to Michelle Canavan, consultant geriatrician. And I suppose the question is, Michelle, what is the plan for access to ICPOP services across the region? And have you any feedback from older persons using the service?
Thanks, Colette, and thanks for the question. Yeah, I mean, we, as I mentioned in the presentation, we had 4 ICPOC teams across the region, and they're divided into areas, I suppose, just to help people understand it a little bit. There's Galway City West and the west of the county. There's Galway City East and the east of the county. There's a team in Roscommon, and it takes in a bit of northeast Galway as well. And then we have a team in Mayo. And there's also either frailty or frailty at the front door teams that may have been in existence before the ECC programme in the hospitals that link very well with these teams. And it just means that older people in those areas have the ability to access these services. From the referral perspective, people might say, well, how do you actually access this? We take referrals from GPs, obviously, primarily, but also we saw in the videos there about the Community Health Network complex care planning meetings. That's a big source of referrals for us, where people are noted to have complex care needs and feel they'd be benefiting from the services that we offer. And I think the plan will be for people to access this care as close to their homes as possible. You know, you mentioned feedback, and one of the biggest feedbacks we got, we did a feedback survey on our initial service, was that people hated navigating traffic, having to park in UHG particularly, and the ability to be able to go down to their local primary care centre or an ambulatory hub that might be a bit more convenient and accessible is a huge thing for people. And I think the other thing we need to do is just kind of, you know, to be in the community and listen to people. And I think having that point of contact is very daunting for people to try and access our health system, particularly all they hear about is trolleys and you know, why they should stay away from ED. And I think this offers a viable alternative and a way of linking them when they do come in the hospital, that we can get people back out. So having that link piece is really important to people, and that would have been a huge feedback for us, be that our social worker, be it the therapy assistant, be it whoever is on the team that they've established a rapport with, and that's really, really important for people.
Michelle, thank you for that answer. Our next question, I'm going to direct this to Anne Cosgrove, Chief Operations Officer in Saolta University Health Group, and it's really around what are the next steps, Anne, in the ECC programme?
Okay, thanks, Colette. I think we can say a lot of work done, but a lot more work to do in the coming months. Over the coming months, we're really going to continue to focus on the recruitment of key staff required to support the delivery of services across all the hubs in Galway, Mayo and Roscommon. And working with our eHealth colleagues and Office of the CIO, we're going to roll out existing systems to support service delivery, in particular our IPIMS, Evolve and HealthLink systems. And they're required to support communication for GPs, for patients and for staff in the hubs and in the hospital. There ultimately will be a national ICT solution supporting services. We're very grateful for the engagement of our GP colleagues to date in the networks. in the cardiology, diabetes, respiratory and ICPOP pathways of care. And we will continue to engage with our GP colleagues to ensure that we actually have the most streamlined patient-centred pathways and processes supporting those pathways as the service evolves. The recruitment of our GP leads into our networks is near completion, and we expect to have full representation in the second quarter of this year. In the ICPOP programme, we'll continue to work on the frailty, falls and cognitive decline pathways. The respiratory pulmonary rehab education programme will continue to develop and expand, and we plan to mobilise a breathlessness clinic following a recent pilot evaluation. We will be commencing a proof of concept with an external company targeting patients with COPD and working with a group of practitioners to enhance pathways with the hubs. The cardiology heart failure clinics will commence in the coming weeks, and work will continue on the diabetic foot pathways with particular emphasis on resolving some of the issues on the acute hospital model of or side of the model of care. Importantly, work has commenced on the identification of patients currently attending our outpatient services in the hospitals, in cardiology and in diabetes, so that those patients into the future can more appropriately attend the services in the hub and receive all of the necessary clinical inputs at the hub level, as distinct from attending the hospital services. And our focus over the coming year will be on seeing increased numbers being treated at the hub or receive their appointments at the actual ECC hubs. And finally, within the networks, the focus will be on further implementation of an integrated approach to case management.
And thank you very much for that really comprehensive next steps really on the ECC programme. I suppose there's a number of questions coming in. Just to reassure people, this is pre-recorded and people can come to this at a later stage in the coming weeks. It's not a problem. But one query has come up, and I'm going to direct this to the four of you in the panel there in the boardroom. Will there be a consultant in respiratory, cardiology and endocrinology attached to each of the chronic disease management hubs in CHO2? I'll open that to the four of you.
I think that is absolutely our intention. And while we're currently focused on the recruitment of posts that have been approved to date, we also recognise that there are some deficits in terms of the posts that have been approved. And so that's going to be part of our focus for the coming months as well, to actually ensure that we have all of the necessary staff, all of the clinical inputs in all of our hubs so that we deliver the service equitably across the three counties.
And certainly from Community Healthcare West, that is our intention, and we will continue to advocate for that and work closely. Thank you.
Thank you, Anne and Breda, for that. There was just a lovely comment in here, and I'm just going to read it. This is a wonderful service being provided by the HSE. We in Galway Parkinson's are aware of the benefit to people with Parkinson's, the interaction with the various consultants in GUH who refer patients to us for physiotherapy, which we provide in 5 venues in Galway City and County on a weekly basis. So they're just saying congratulations and acknowledging the work and their involvement in the integration that they have currently with our services. I suppose on a final note, we're coming to the end of our webinar, and I would like to thank everybody for their time here today and coming to join us at lunchtime. This is a very important first steps, I suppose, in communication for all of us across Community Healthcare West and our Saolta Hospital group around the ECC programme. And I would like to introduce our final speaker, who's Tony Canavan, our CEO of the Saolta University Healthcare Group.
Thanks, Colette. I suppose, first of all, on behalf of myself and Breda, we really want to thank everybody who presented at the webinar here today, everybody who contributed to the webinar with their pre-recorded videos and so on, and in particular maybe to pick out service users for their comments and for their contributions to the webinar. I think that's been extremely useful. Just as Colette said, I also want to thank everybody for joining in. Well over 400 people have attended this webinar this afternoon, which I suppose shows the level of interest that there is in the ECC programme. But we appreciate that as well. We appreciate the time and effort that people have given to attend. I think communication is really going to be an important part of the role of the ECC over the coming months and years. If you think about the region that we work in, it's a very broad geographical region with a very diverse population, with multiple stakeholders across a range of different services, both services provided by the HSE and services provided by others as well. So communication within that context is really, really important, and of course it's really difficult as well. And this webinar this afternoon is part of a process of trying to ensure that we continue to engage with people around what we're planning to do, how we're doing it, and how we can improve on that as we go forward as well. The Enhanced Community Care Programme is, of course, a priority at national level. As Breda pointed out earlier on, it's part and parcel of the Saolta Care Plan. But I think for us, and for those of us that live in the West of Ireland, it absolutely makes sense. And when we look at how it can help to support rural-based populations, as much of the population in the West is, the Enhanced Community Care Programme is really, really important and just makes sense on this side of the country. And I guess in a way, when we talk about all of the staff that have been recruited to the Enhanced Community Care Programme, 372 people, I think was mentioned earlier on. It's great. It's really good this afternoon then to see how those people are already starting to work together to develop pathways and to deliver care to patients and to service users in the West already. And we look forward to developing that further. There's no doubt that we're entering another stage of change again within the health services, and there'll be significant changes, I think, over the coming years. I really look forward to ECC being a really important part of that change for service users and people that use our that access our care. But I also really look forward to working with yourselves, all of the stakeholders that are working within the services on the changes that are coming up. Thank you.